I think we can start now.
Yes.
Hi, everybody. You are all welcome to our webinar. We are going to talk on the postgraduate infectious diseases training and its standards. And first of all, I would like to introduce myself. I'm an infectious disease and clinical microbiology specialist, and I have the full title of full professorship, and I'm the lead of IDERA, and I think IDERA is, as for today, I'm proud to say, is one of the largest clinical research platforms worldwide, perhaps the largest one. We have thousands of members all over the world. First of all, uh, we have two distinguished speakers. One is Professor Bojana Beovic. She is a full professor of infectious diseases at the Faculty of Medicine, University of Ljubljana. She has obtained her medical doctor, Master of Science and PhD degrees from the University of Ljubljana and completed board certification in infectious diseases at the University of Medical Center Ljubljana. Her postgraduate training includes pharmacology studies at the University of Zagreb and advanced clinical education at the University of Wisconsin Hospital and Clinics. And she has also served as a visiting professor in Trieste, Italy. She has been affiliated with the Department of Infectious Diseases at the University of Medical Center Ljubljana since 1986 and served as an attending physician in the intensive care unit from 1993 to 2013. She currently heads the Infectious Diseases Consultancy Service at the Antimicrobial Stewardship Program at the University of Ljubljana. Professor Beovic was the president of the Slovenian Society of Chemotherapy from 2004 to 2018, and since 2019, she chaired the intersectional coordination mechanism for the prudent use of antimicrobials at the Ministry of Health. She has led the antibiotic committee at University of Medical Center Ljubljana since 2008. Within EKMUD, she served as an honorary secretary starting from 2009 to 14 and chaired 2014 to 2018 of the study group for antimicrobial stewardship. And currently, she coordinates the EKMUD antimicrobial stewardship certificate program. During COVID-19 pandemic, she chaired the scientific advisory committee to Slovenian Ministry of Health. Since 2021, she has been the president of the Medical Chamber of Slovenia. And also, Professor Beovic is the author and co-author of more than 350 publications in national and international peer-reviewed literature. So we have a distinguished speaker here who will talk on the European perspective on the infectious diseases specialty training. The floor is yours, Professor Bojana.
Thank you very much, first of all, for the invitation and also for the kind introduction. I will start sharing my slides. Yeah, you see them? It's okay? It works?
Yes, everything is okay.
Thank you. I will speak about European perspective on specialty training in infectious diseases. I hope I will tell you something interesting in the next 20 minutes. As said, I have several affiliations. One of them is also related to the medical chamber, where I'm also responsible for the ID postgraduate training. Otherwise, I don't have anything to disclose. Speaking about the education of infectious disease specialists, we have to ask ourselves first what kind of competencies we believe that an ID specialist has to possess. And this is from a European document. I will explain a little bit later. But the idea is that an ID specialist should be a medical expert, but also a communicator, a collaborator, a leader, a healthcare advocate, a scholar, and a professional. This is pretty generic. But if we go more into the details, there are quite many papers showing the role of infectious diseases specialists. If I go quickly just through some of them, ID specialist is often involved in clinical care of complex infections, together with surgeons, transplant physicians, and so on. Then is usually the leader of antimicrobial stewardship teams, is involved in infection prevention and control and hospital epidemiology, in outbreak responses and public health, in diagnostic stewardship, in vaccination and prevention, research and innovation, education in training and in its field, and also on the system level quality improvement and policy, like with guideline development care pathways, institutional and national policy support. As it was already mentioned, I believe that several of ID physicians have been heavily involved in COVID pandemic as well on the national level. The medical education in general, together with the healthcare, is in European Union not really the responsibility of the European Union. That means at the level of European Union, this is the responsibility of individual member states. But there are a few documents, this is one of them, that are important for the recognition of professional qualifications. And in this document, this is a directive from 2005. There is an Annex 5, speaking about doctors of medicine. And this is actually a list of specialty trainings per country and their minimum duration. In this directive from 2005, infectious diseases are called communicable diseases, and it is 4 years minimum training. I highlighted already that this directive was adopted in 2005. This is quite many years ago. It's 20 years ago now. And in many countries, specialty training is longer than 4 years. And there are also other specialties now in place in several countries. So at the European Network for Medical Health Competent Authorities, these are the institutions that are responsible for postgraduate training in member states, usually medical chamber, but could be agencies at the ministry and so on. We did together a survey, what is going on in specialty training, also regarding the duration. And now this survey, the results of the survey have been just submitted to the European Commission with a proposal that a new directive or a new annex is added to the directive stating different durations of the specialty training. You may imagine that in some countries, this 4 years in the directive could make a conflict between the professionals who want longer treatment training duration, and the politicians, of course, who look at the directive and say in Europe it's just 4 years. Another institution I would like to mention is the UMS. This is the European Union of Medical Specialists. This is not a state agency or something like that. This is actually a professional organization. And the activities of the UMS could be divided in 3 pillars. The first one is the postgraduate training, then continuous medical education, and advocacy for medical specialists. And if we look more in details in postgraduate training, we could see that UMS is responsible for the creation or wants to create high-level, harmonized European postgraduate training requirements. That is something that is broader than just curricula, I will explain later, and also is trying to organize European board exams. More than 70 UMS adopted European training requirements are in place at the moment. And here you could see also infectious diseases that was adopted in 2018. This is the first page of the document. You could see the date of the approval. And if we go to the content of this document, it is not only about the curriculum, it is not only about the organization of the training, the schedule, the governance, but it's also about the training requirements for the trainers. That means the mentors, who could be a mentor, and so on. And in addition, the training requirements for the training institutions. That means what should an institution have in place that it could provide a training position for an future ID specialist. If we go more in details in the curriculum of the training by UMS, these are some features that may be interesting. The recommended duration is 5 years, but preferably 6 years. And the 2 years must be in internal medicine, could be together with trainees of other internal medicine branches, or it could be just separate only for the ID physicians, but 2 years in internal medicine, and also at least 6 months should be spent attached to or working in an approved clinical microbiology department. These are the 2 requirements that are important for the ID training. And the curriculum consists of 7 objectives. The first one are the community-acquired infections, then healthcare-acquired infections, antimicrobial stewardship, and infections related to healthcare, then non-HIV immunocompromised, important infections, health advice for travelers, infections-related problems of travel, then public health in relation to infection, outbreak and vaccination, the use of microbiology technique, and the 7th objective is research and audit methodology. If we look more in details in, for instance, just as an example of community-acquired infections, here you see the list of knowledge: acute viral hepatitis, bone and joint infections, central nervous infections, and so on. And each objective is divided in the knowledge. See my arrow? The knowledge, the skills, and the behavior. This is all what should be achieved by an ID trainee, and we also stated the various assessment methods that are relevant to each part of this objective 1, for instance, and so on. The same principle with the other objectives. What is the current situation in ID training in Europe? This is a recent survey that was published this year, and we collected the data in 2023. As you see, in most of European countries, infectious diseases is independent specialty. In some countries, such as Greece, the Netherlands, the Belgium, and the Cyprus, it is a subspecialty, and there's still one country in which infectious diseases have not been recognized as a specialty yet. This is Spain, and this is really a surprise because I believe we all know experts in infectious diseases from Spain, but they are recognized in their country only as internal medicine. So this is a long battle, and we are supporting our colleagues in all kind of ways, but up to now they haven't succeeded yet. Maybe in the next few years. The duration of training, the median is 5 years, the range 2 to 7. The duration of ID training with ID specialty is, of course, longer than in countries with ID subspecialty, but also in some countries, the duration of specialty, not subspecialty training, could only be 2 years. This is from the survey I have mentioned that was performed by European Network of Medical Competent Authorities. Just recently, you see in some countries the duration is more than 6 years, like in Norway, there are quite some with 6 years and so on, if you want to see the details of individual countries. What also came up from this UMS ID survey that I mentioned earlier, the internal medicine is a component of all programs with the median duration of 2 years, which is concordant with the European training requirements. Then medical microbiology was only included in a little bit more than 1/2 of the programs, with the median duration of 1 year, but only 1/4 of the countries included at least 6 months of medical microbiology training recommended in the ETR. So here, the individual training curricula have not reached this agreed European training requirements. 2 countries, as you know, Turkey and United Kingdom, recognize combined ID and training. Our colleagues here with us are both. Tropical diseases and pediatrics are included in all programs. Tropical medicine is only recognized as independent specialty in Slovakia, Switzerland, and United Kingdom. And pediatric ID was reported as a specialty in 6 of 35 countries that were included in the survey, and the subspecialty in something more than 1/4 of the countries. In the second part of my talk, I would like to tell you something more about European board exam. This is the group that had worked with the exam, and the exam took place almost a year ago in January 2025. It was an online exam with a remote proctoring. This is an agency who provides the platform and also provides the remote proctoring in English with 100 questions in this pilot. It took 3 hours. The structure of the question was uniform, more or less the same for all 100 questions. All questions started with the STEM. This is a short case story with relevant laboratory and imaging results, and also if relevant information on epidemiology is revealed. If there's a question about the choice of antibiotics, for instance, in a patient with pneumonia or skin or soft tissue infection, then the share of MRSA is given in the setting, and so on. So, and there are 5 plausible answers in these multiple choice questions, and single best, not correct answer should be chosen, because it's difficult to speak, you know, in medicine, nothing is 100%. We cannot speak about correct or wrong, but single best answer. I will show you just one example of such a question. You see a 24-year-old female was found somnolent in her room and so on, and a year ago she had a car accident, and this is a situation on admission with some vitals and some laboratory. And then here you see the relevant epidemiology and what is your advice for empirical antibiotic treatment. And here you see vancomycin plus ceftriaxone, and also group who wrote this question should provide a reference for the answer. Of course, the candidates do not see the answer and the reference, the correct answer and the reference, but this is something that should be provided by each questions during the development of the exam. The blueprint of the exam covered virtually all the objectives that are part of the training, of the curriculum, as I've shown before. Community-acquired infections represented 10% of the questions. Then long-term conditions such as TB, hepatitis, HIV, 10%. Antimicrobial stewardship, hospital-acquired infections, 15, and so on, up to 100%, of course. So it depends. Researcher and audit methodology, 5%, and so on. These are the results. We had 113 candidates. 51 of them were already specialists. They tried themselves at the exam to see how it's working. And most of average duration of the exam was 141 minutes, so less than we expected. And on average, each question took almost 100 seconds. And these are the exams. These are the results by ID training. There is, you could see a growth in the median or in the range, but not so much. And the mean correct response by ID domain, you see the device-related infections. Here, the correct results were not so common, were really common in non-HIV immunocompromised, for instance, and also in research. People don't know so much, or public health. You see, these are the results. We also look at the country, of course, in an anonymous way, and we only compared qualified specialists. And here you see the range of the medians from country to country was from 63 to 75% score rate. After the pilot exam, what can I say? The price of the platform is quite high. There is no sponsorship for this platform, so we have to collect money from the participants. And of course, this fee is relatively high for the candidates if we want to cover the platform with the fees of the candidates. And it's also a lot of work with collecting and editing the question. It is very difficult to get really many questions. You could imagine if you want to repeat the exam each year, we should collect almost 100 new questions, or at least one half should be renewed. What is the motivation for the candidates? The exam does not provide any official credentials. This is not an official state-recognized exam. This is just something that is organized by UMS, and by definition, UNS is a non-governmental organization. It is not a state agency or something like that. But on the other side, the exam provides a good formative test for the participants. That means we sent from Slovenia 4 candidates to the pilot exam, and they tested their own knowledge. They knew where they are with their knowledge, what they should repeat, and so on. For the end of my talk, of course, we are all striving to harmonize the education, but we have to be aware that infectious disease specialists have various assignments in their countries. In some countries, we do have dedicated beds. In some hospitals, there are no beds. There are just consultancy services and so on. In some countries, they cover infection control and antibiotic stewardship. In the others don't. So it could be different. And what is also different, of course, is the epidemiology of infectious diseases. This is also something that should be taken into account if we want to harmonize the ID specialty education. And I hope I'm not really too long. If I would just briefly like to mention 2 additional programs that are available for ID specialties after the graduation, after the board exam. Both programs are provided by EKMUD. One of them is the USIC, this is infection prevention and control, and the other one is antimicrobial stewardship in Europe. This is a 2-year program. I will not go into all the details because I'm really running out of time. For the conclusion, I'm sure that harmonization is necessary to ensure high level of quality of postgraduate education and to provide comparable healthcare services for European citizens. And the European training requirements represent an important step forward toward harmonization. And the pilot exam also demonstrated a relatively comparable knowledge among the participants. However, we have heterogeneous epidemiology and varying infectious diseases workload, which necessitates locally adapted training programs. And in addition, probably we also need a subspecialty training for certain infectious diseases activities, such as infection prevention and control, and on the other side, antimicrobial stewardship. So thank you very much.
Thank you very much, Professor Boyana, for the very nice and comprehensive presentation. Now we have a couple of questions, but let's proceed because the two speakers are focusing on the issue from these different perspectives, but with a similar background and point of view. Now let's continue with Professor Zeliha, and after then we can discuss the issue in detail altogether. I would like to introduce you Professor Zeliha Koçak-Tufan. She is a distinguished leader whose career seamlessly integrates medical expertise and higher education governance and international science diplomacy with a strong commitment to research integrity and global collaboration. She is basically a physician and infectious diseases specialist, but a former bureaucrat and a former diplomat. She currently serves as a faculty member at Ankara Yıldırım Beyazıt University, affiliated to Ankara Bilkent City Hospital, and her multidisciplinary career bridges medical sciences, higher education governance, and international science policy, combining clinical expertise with leadership in global academic collaboration. From 2020 to 2024, she represented Turkey as a consular at the Turkish Embassy in Washington, D.C., where she led bilateral initiatives in education and science diplomacy, academic partnership, and research integrity between 2015 and 2022. She served as a member of the executive board of the Council of Higher Education in Turkey, where she worked on higher education policy, recognition of qualifications, as well as in developing and implementing standards for medical and health sciences education. Recently, she was selected to serve in all European academia's Research Ethics and Integrity Council to represent the country. Professor Zeliha Koçak-Tufan will talk on an IDRS study now, analyzing the IT specialty training in 29 countries, starting from Southeast Asia to Central Europe. And the country analyzed, now we have recent European perspectives from Professor Bojana Bejovic, but the study will focus on the countries from Eastern Europe like Russia, Moldova, Romania, and Bulgaria, from Southeast Asia, India, Pakistan, and Afghanistan, Malaysia, from the Middle East, Iran, Saudi Arabia, Jordan, Iraq, Oman, the United Arab Emirates, Qatar, Lebanon, and from the Southeast Europe, Albania, Greece, Kosovo, Slovenia, Bosnia and Herzegovina, Serbia, the Republic of North Macedonia, and Croatia. The floor is now yours, Professor Zeliha.
Thank you for this introduction, and I want to thank to EKMUD first, our Infectious Disease and Clinical Microbiology Society, for inviting us and making this possible for us to come together with colleagues from different countries. And a lot of thanks to you and our colleagues from different countries making this article possible. So Dr. Boyana already stated about the European countries and the ID infectious diseases education there. And I will talk about this IDIR study, which was published recently. And these were the authors. Actually, it would be impossible without Dr. Selcan or Dr. Hakan's network and dedication about making this collaboration. From 29 different countries, it's very hard to collect this data, make this network, and publish this kind of articles. I just helped about the structure of it and try to add some more. So, what were the regions for the article? From Central Asia to Southeast Asia, already Dr. Hakan mentioned about that. There are 29 countries represented in this article. It's our near geography, let's say, from the neighbors of Turkey as well as the a little bit far away countries, but we are collaborating with those countries as well as Europe, of course, but it's already presented. And I want to state about this as well, because about coming to geography, sometimes Turkey is mentioned in Asia, sometimes in Europe. Why we prefer to set Turkey as a separate country in this article is that because of these differences. According to WHO region, Turkey is in Europe, so it is a European region country, but for UN, it's a Western Asian country. It's a transcontinental country. But just to be professional in our articles, it's good to know that if you're just writing the big picture, you can mention that in Europe, but if you are collecting like Southeast Europe, Eastern Europe, Western Europe, etc., you can use the UN definition this time. So we wanted to separate Turkey as a different country here. And for the income levels, sometimes even for this year's estimates poster, I saw low middle income country. It is not a low middle income country. Just letting our young fellows know it's upper middle income country according to World Bank income level. So it's good to mention this to be professional in our writings. And also there is no Middle East normally. It's used as well as for in the political area, but historically it is Western Asia. This is the Eastern Mediterranean region according to WHO and Western Asia according to UN. There is no Middle East for the geographical differences according to WHO and UN. But we are using it as a political term, as a cultural term as well for the last 70 years or 100 years, let's say. So these are the UN geographical continents and countries for those who wants to make more collaborative studies. But were the standards? The standards were already mentioned by Dr. Boyana, so I'm not going through this, but all countries have their national programs as well. Just letting you know that we are also obeying the European directives, the 2005/36. And for our bachelor degree for the recognition and qualifications as well, as Dr. Bayona already mentioned, and we're also following the UAMs, but we do have our local guidelines, local core elements and curriculum for ID education. How about entering the ID career for different countries? Any kind of exam is required. Almost 60% of the countries joined in our study. For those who doesn't need exam, actually they're for after internal medicine or after pediatrics. How about the occupancy rates? I think it's the well-known issue that ID specialty come a little bit popular after COVID. So it's similar in different countries as well. As the occupancy rate is always more than 80% in our study. It's not like this in America and other continents maybe, because it's almost 50 to 60% there and 40% are empty as far as I know in the US. The perception of ID specialty in a post-COVID area is usually high, but it is the lowest rating reported from Slovenia is 1, and the highest from Iraq, Malaysia, and Uzbekistan is 5, but still the median was 3.5. And the participants from 19 countries indicated that ID is recognized as an independent specialty program like Europe. In countries like Greece, Jordan, Oman, Qatar, Pakistan, India, Lebanese, and Malaysia, it is after internal medicine. In United Arab Emirates and Saudi Arabia, it's after internal medicine or pediatrics. So these are the tables there are a lot of data inside it. I would refer those who wants detailed information, they can go directly to the article. It's an open access one. But as you see here, those who in the first section and the second section, those who doesn't need written exam usually have exam in internal medicine while entering the internal medicine specialty. If it's a subspecialty, they don't need exam. But if it is a separate and independent specialty, they usually have entrance exam. And the total ID training centers are very different among different countries. Let's say for Greece, it is more than 10. In India, it's more than 10. In Iran, it is more than 20. And in Malaysia, more than 10. Russia, it's 81. In Saudi Arabia, it's more than 30, even more than 80 in Turkey. We will come to that. This is the table for Turkey. And the centers are more than 80 total ID training centers. And the total ID specialists in Turkey is, here it is written more than 1,200. It is, as far as I know, it is more than 1,500 anymore. It's for years, it's more than 1,500 anymore. But the total ID specialists in other countries are far more less than that. In Iran, it is 12,000. And in Russia, it is more than 7,000. In Romania, it's like 1,400 as well. The duration of the ID specialty is, like Dr. Boyana says, it's usually 4 to 5 years, but there are 7 countries who have just 2 years, and 7 countries more than 5 to 6 years. So how about the ID career itself after entering the ID career? So there are opportunities for training abroad in some countries, and some countries needed PhD after the thesis after completion of infectious disease specialty. And for academic career pathway, PhD is required in some countries. No PhD is required for Turkey because the specialty training in Turkey is equivalent to PhD. That's why academic career can be confirmed after completion of the specialty directly. And how about the rotations and the integral components of ID's specialty? And mainly the internal medicine and microbiology as the core components of all programs, and also infection control, epidemiology, and antimicrobial stewardship, of course. And sexually transmitted diseases, travel medicine, and transplantation were included in selected programs. The health economics are coming popular day by day, and it's also appeared to be included in Jordan. Palliative care was included in Slovenia, but intensive care unit in Turkey, let's say. The rotations in pediatrics, cardiology, neurology, hepatology, and intensive care were integrated in some curricula, not in all of them. So about the teaching methods, it's more or less the same, but it's improving according to modern times, in the post-COVID times, let's say. Interactive and learner-centered methods such as simulation-based training, mobile applications, role-playing, and scenario-based learning remains limited to some countries and some centers, but it's growing in numbers day by day. There are also some invasive procedures that are required to complete an ID training, like lumbar puncture, urinary catheter insertion. But let's say some centers need skin biopsies, endotracheal intubation, abdominal paracentesis as well, like joint aspiration. It's a broad range of difference from center to center about the invasive procedures that are needed to complete the infectious disease training. The compulsory training in other institutions are seen in Kosovo, Oman, Croatia, Saudi Arabia, and Kazakhstan. It is just to make more practicing, more patients, getting more experience, and it's a good thing actually to have this, of course. Sorry for that. I will come back to this slide. Yeah. In Oman, ID specialty trainees need to complete a fellowship abroad for at least 2 years. In Saudi Arabia, trainees rotate through various hospitals and may spend 1 year in Canada. Okay. So the ID career after fellowship. Some countries have subspecialties in different areas, let's say intensive care, parasitology, HIV and AIDS. It's a separate subspecialty in some countries, immunology, epidemiology, microbiology, and so on. And another issue is the license renewal. I think it will be important for other countries as well, but for now, 9 countries reported to have mandatory periodic license exam for ID specialties. And the most common renewal period of the exam was every 5 years in 6 countries, let's say for such as Azerbaijan, Iran, Russia, Kazakhstan, Kyrgyz Republic, and Moldova. In Croatia, the period is 6 years. In Serbia and North Macedonia, it is 7 years. And why the article is important, because in growing numbers, we see the international mobility, the brain circulation, we call it, and how about working in other countries to make an international career in ID. So this is a very good report from OECD about the international immigration outlook in last year, 2025, and about the health sciences. More and more international movement and migration are seen in health sciences, especially in nurses and other programs, but also in doctors as well. Let's say even for United Kingdom and Ireland, they are going different countries. And the recognition policies are changing as well, especially after COVID, let's say. But Germany comes the first one. For the last 10 years, they are making everything easier for international mobility and the brain circulation. Germany, known as a tough country, like 15 years before, 10 years before, about their recognition processes. But now they're simplifying the recognition conditions in the context of the free movement. That's very interesting. For those who are working on the recognition of the qualifications, it's an example as a best practice, let's say. Because the young want to move around, they want to make research with other centers, they want to go around the world, they want to explore their potential as well, and they're searching for the better. Sometimes they just want to see other countries, and they're making it easier and welcoming environment for research ecosystem and higher education ecosystem. So there are also nonlinear careers are growing, and people are going to industry for jobs. So it's also important for recognition, for changing the career. So this is the EKMUD network of Europe. We also follow the 2005, 26 EC directories and the updates of them. The EKMUD network is the part of the European Union's recognition and qualification system. Turkey is following this path as well. There are some rules in it, and it's making easier for documents to be recognized by other countries, if you know the mindset, of course. Otherwise, of course, each country has its local needs, and they can change the curriculum accordingly. About US, I don't want to talk about the US, but just stick on the article we mentioned, but just letting you know, because it's also among the international mobility, that each country has their different education system. Let's say in US, you have to go to a college first, a 4-year or 5-year degree, and then you go to medical school, and then residency and fellowship, and then you have to take some exams. And it is the exams are equal for everybody. You don't have to go another exam for recognition. So USMLE 1, 2, and 3 is for US citizens and for those who are coming from other countries as well. But other countries, they can apply different exams for the foreigners, for the international graduates. And while recruiting for others to our countries, we have to be aware of that. If they are coming directly, completing from their specialty, and if they don't make their thesis, and if their specialty is not recognized as PhD, they cannot follow the academic career in our country, let's say, or for other countries who are the specialties are equivalent to PhD and can go to their academic career directly. So in our article, in our study from those 29 countries, almost 35% of the countries reported a PhD requirement for academic career. So their specialty is not directly equal to a PhD career. So this is another report from Clarivate. It's also important for our region, I guess, because it shows who works with who goes to where, who publishes with who. So among our region, let's say the Western Asia and Northern Africa, and from 5 years period, Iran and Turkey comes the most publishing countries in the Web of Science. These are the growing numbers of the publications. It's 10 times more, 10 times more publications these years in the Web of Science. And the research mobility is also underlined in this study, that who goes where. Turkey goes everywhere. Let's say Turkish people goes everywhere and accepting from everywhere. But Morocco, Algeria, Tunisia goes to France. The language, of course, it is also important. The United Arab Emirates, Qatar, and Arabia goes to UK, works with them and publish with them. And Egypt goes to Saudi Arabia. These are some kind of research mobilities and working culture of the countries. And according to this report, Turkey is writing domestic reports mainly. So, but the international reports are growing in number day by day. This is so the Turkey, Iran, Egypt, Tunisia, Algeria, and Morocco were performing less well about the international collaborations. That's why this article has another importance to make more collaboration with other countries. Turkey is publishing or getting collaboration with UK, with United States the most, Germany and UK. And especially from the other countries, the differentiation of Turkey is publicating in medicine as the first line. So by contrast to other, it has a particular focus on specialist areas of medical sciences. This is the potential of Turkey, actually. So in our article, also, we stated that international collaborative papers have an average higher impact than purely domestic papers, partly because collaboration implies an endeavor to solve major challenges not amenable to a solo effort, but also because the paper reach a wider audience. That's very important to know each other's systems, know the core curriculums, of course, and collaborate more and more. So that was the importance of the paper. So this is my hospital, Ankara Bilkent City Hospital. It is 6 hospitals, 4,000 bed hospitals. For those who want to collaborate with us, they can reach us too. And I wanted to thank you all for listening. And I think, yeah, it was 20 minutes already. Thank you very much. And if there is any question, I would be happy to reply them.
Thank you very much, Professor Celia, for the nice presentation. I'm more than happy that you have delved into the details of our study. And in that case, I think most of us, including me, has a better understanding of the interpretation of the data we have. I'm very happy to say that 29 countries has joined the study, and the data providers are mostly very well distinguished people, starting from Bojana from Slovenia to Dr. George as the president of Indian Infectious Diseases Society, as Sotiris as the president of Greek Infectious Diseases Society, as Tiberia Holban, as the president of Moldovan Infectious Diseases Society, Mesut Mardani, the president of Iranian Infectious Diseases Society, Sova Kant as the president of International Society of Chemotherapy. So the team is very tough. So these, high quality brains provided inputs into the study to provide a clearer understanding of the postgraduate infectious diseases training. As you know, in Turkey, we have evolved greatly as the infectious diseases specialist for the last 30 years. When I was a fellow, I remember that as the infectious diseases department, we were the least antibiotic using department inside the hospital. We were only focusing on community-acquired infections like brucellosis, meningitis, etc. But in due course, everything has changed, and now the infectious disease specialists are running into all types of disorders that has the potential to get infection, starting from neurosurgery department putting implants or cardiac surgery patients, after surgery, etc. And immunocompromised patients, HIV patients. Most of the time, 30 years ago, we were more like a laboratory specialist, but now we are real infectious diseases specialists in the time. So congratulations for the team. Now, I would like to bring some questions into your attention. Let me check. I had seen a question from Dr. Bülent Fetvacı. He asks if HIV should be or is a subspecialty under infectious diseases training. What do you think?
Dr. Boyana,
Well,
according to growing number in Turkey, I can take the second step, but please go ahead.
Yeah, well, in Slovenia, I will start here. We have very few patients with HIV. And this is why all these clinics are centralized in one hospital. And this is just a small group of doctors that takes care about these patients. But this is one side. If the HIV community is small. But if you look at the European training requirements, HIV is the part of the curriculum. It belongs to the chronic infections, and a certain level of knowledge is needed for each infectious disease specialists. I believe. So these are the two extremes, so to say.
Yeah, sure.
So the HIV is also in Turkey, it's inside the curriculum, but the high rocketing, just if you take into account that the high rocketing of the numbers of the HIV cases in Turkey is growing numbers every single day. It could be a subspecialty because I think it depends on the numbers of the infectious diseases specialists in a country. If you have 1,500 specialists in a country, and if your hospital has enough ID specialists in antimicrobial stewardship, in hospital infection control, in outpatient and in departments and in wards, then you can decide it as a subspecialty, or there could be some specialists who are dedicated to HIV, like in Turkey. It's not a subspecialty yet. It's very hard for me to say subspecialty, by the way, but it's not a subspecialty yet. But there are dedicated doctors, dedicated specialists who are dealing with HIV. But depending on the growing numbers, it can happen. It can happen in Turkey because we have 1,500 infectious disease specialists plus 1,500 microbiologists in our country. But not all countries are such. They don't, even Spain, they don't have an ID specialist in their country, although they are very active in ASMED. Our colleagues are very active in ASMED. So it depends on the country's needs and the number of the patients, I guess. So we cannot say that it must. So it depends on the country's needs.
Great.
Yeah. But if I may add, a certain level of knowledge and skills managing HIV patient is needed for every ID specialist, probably. And then we speak not so much about subspecialty, but about a physician, an ID physician being dedicated to HIV or transplant or maybe bone infections and so on. It, depends.
Yeah. So it's in the core curriculum for everybody, I guess, already. Mm-hmm.
Thank you very much. The issue is we will impose some different points of views in the course, I believe. Sexually transmitted diseases and the problems of these patients, it extends to the boundaries of psychiatry on one side, on the other hand, to the pharmacology, clinical pharmacist issue, etc. It's a huge area that should be focused on. Then, I have another question to you. There are a couple of questions, but when we are to talk on a subspecialty issue, I would like to ask your opinion about the discrepancies in the training curricula of infection control teams and the classical infectious diseases training fellows, okay? What do you think? Should we separate them as two distinct specialties, or would it be an, subspecialty under infectious diseases? For
This is a question for Professor Zeliha or myself or both of us.
It is a quite different, expertise compared to regular infectious diseases training, consultations, patient management, etc. It has a different, area. It is a different area of expertise, stretching to administration on one side. On the other hand, the financial issues, management strategies, administrative issues, etc. So do you think that, a regular infectious diseases specialist should be more, proficient in infection control issues, with the understanding that it should be on a different, it should be a different subspecialty?
I can start with this if you want, Dr. Boyana.
Yeah, well, I don't think that we will recruit really many medical doctors to start infection prevention and control specialty from the scratch. And I believe that infection prevention and control is a teamwork. It's managed by a team, and infectious diseases specialist is an important team member, together with infection control nurse, together with somebody who is an expert in sanitation, in water supply in hospital, in environment, things like that. But of course, with the time, as we said before, for HIV, dedicated ID physicians, here we also have dedicated ID physicians. And it is, of course, also useful that these dedicated infection control ID physicians have some additional training. Similar to the training provided by USIC, for instance, or maybe there are other trainings elsewhere.
Before Zeliha, I would like to clarify my question for the fellows, listening us. For example, as an ID specialist, I'm going to the intensive care unit and I see a patient there which is infected with Klebsiella pneumonia, carbapenem resistant, even colistin resistant, ceftazidime avibactam resistant, and the patient has a critical status. We are trying to decide how to manage the case on one side. But if you are working in an infection control department, somebody comes to you and shows you an clothing made of, rubber or another type of regular clothing. The guy asked, which one is more suitable for infection control purposes? How about the, filtration? How about the negative pressure? This is far beyond the clinical management of the cases. So do you think that they should be, integrated under the same specialty, or they should be separated as two different collaborative specialties? Celia.
Actually, this is the core of our education, the antimicrobial stewardship and the hospital infection control. This is the core of our specialty because you can deal with travel medicine as well. You can work in a clinical microbiology laboratory as well in Turkey, I mean. Because we are getting both title, infectious disease and clinical microbiology. But the core is the hospital infection control and antimicrobial stewardship. I agree with you. There could be some dedicated persons dealing with the control team, infection control team, of course, also consulting the ICU and taking care for the patients. But the basics of it that you have to have a common understanding of infectious diseases control and practices. Without this common ground, you cannot make both of them. So you cannot be a very good ID specialist consulting an intensive care without knowing the core elements of infection control. But as Dr. Boyana already stated that, in the core curriculums of Europe, it starts with the communication. the communication issues are very important. Those practices are different than the specialty training, but they should be included as well as an infection control practitioner. According to UMs, the clinical microbiology specialists also have to deal with the infection control team. They are also a member of the infection control team, and they have to deal with the antimicrobial stewardship as well. And they are not consulting patients, but we are doing both. So I think it's very important to know the common ground. These are the common grounds of our specialty. But of course, you can dedicate it to one and you can go into detail about the hospital infection control, the materials, the texture, the hand disinfectants, etc. Or you can be dedicated to travel medicine depending on the region of your country. In Africa, you can be dedicated malaria doctor or HIV doctor. But for common ground, you have to know the infection control practices, both for malaria cases and HIV cases too, because there are no other specialty dealing with these issues. This is only us. So it should be together, but subspecialty or certificates, you don't have to open it to each case for subspecialty, but you can make certificated education like in us.
I think, yeah,
Exactly.
this is very nice, but we are professionals and we have time to time different points of views, time to time overlapping, time to time intersecting. I remember reading a paper by Fiona Cook in Lancet more than 10 years ago. I think Fiona was, still working in Cambridge, and she was focusing on the postgraduate infectious disease training. And I remember she wrote a very explicit sentence saying that the infectious disease training should be based on three major topics or three major pods. The first one is internal medicine, and the second one is the epidemiology, and the third one is the clinical microbiology. I totally agree with it. But other than this, we have very many common grounds. To a degree, yes, we should be, inside the other disciplines like epidemiology, like, infection control on one side, like clinical microbiology on the other side, because we're not internal medicine specialists. We're not just looking at the antibiotic susceptibility data and providing antibiotics. We have many concerns in our brains. So I believe that, the infectious diseases in the course should focus on putting subspecialties after a common ground training, like, sexually transmitted diseases, infection control. Otherwise, there will be people working for every field. Every field. Today I will work in the intensive care unit. After a couple of months, I will work in the clinical microbiology laboratory, or in infection control department for infection control issues, etc. I think we need subspecialties after a common training.
But this is a kind of focusing area, Dr. Hakan. It's not just subspecialties areas. Even in UK, they're working in laboratory as an internal medicine department as a consultant, etc. So I think so there could be dedicated people on special areas, of course, but specialty is a common ground. So the clinical rotations with different hospitals, I agree with that part. From other countries, we see that there are a lot of countries they ask for their fellows to go even abroad to see the patients to enlarge their knowledge. Let's say Dr. Boyana can send their fellows to us to see more HIV patients, let's say, or chronic hemorrhagic fever, viral hemorrhagic fever patients. So to make the education board broad. But making everything subspecialty is different thing. But of course, there could be dedicated persons, and these are the focus area of each specialist or professor's interest area. Let's put them in the interest area. But we will see in the future if it will grow in number more.
Yeah.
We'll see.
This is a very important point. Yeah, we can stop this issue here, but there are a couple of words I would like to say. The first
Okay.
is a basic executor. The common ground training is okay, but for, having skillful decision makers, I think we need subspecialty training and departments focus on these particular issues rather than individually any dedicated people. I think subspecialty should be considered. This is my point. And
Okay, you are the moderator.
Yeah, well, it's true that at one point somebody working in an area needs a formal certificate for it. If it's about designing a hospital or a new part of the hospital, you need this infection control input, and here you need a person who is a certified infection control expert. These are situations, but it depends, maybe in a smaller country hospital, it's just one ID specialist who does ID consults and at the same time is interested and works in infection control. It's flexible, but I would not say that for somebody who works in infection control, it is not necessary to do the clinical rotations at the beginning. Because this is how this infection control person in the future will know what it's all about with the basic clinical training. Without it, being just an expert for the rubber gloves, I believe it's not enough.
This is the other side of the medallion. I remember reading a paper published in the New England Journal of Medicine related to the cardiology specialty, and the title of the paper was Internal Medicine, Specialization, Subspecialization, Subspecialization, Subspecialization. When you look at the cardiology, there is stroke, advanced stroke, electrophysiology, failure, etc. There are many subspecialties. I don't mean losing the ground. But on the other hand, on one side, it should go in a more professional way. I think we'll discuss this issue. And one more thing, we have a question here, I think, to Professor Boyana. It came from Refika. Refika is my fellow. We have many smart fellows, by the way. They are now watching us. She asks, how do the differences between the postgraduate training in infectious diseases following after internal medicine residency and direct postgraduate training in infectious diseases and clinical microbiology manifest themselves?
I think it varies from one country to another. In some countries, for instance, in Slovenia, we do not have a common trunk with internal medicine, but our trainees do the same tests at the end of a rotation in hematology, cardiology, pulmonology, and so on. The test is the same as internal medicine trainees. This is how the level of training is similar, but they start infectious disease training from the beginning. It is not the common trunk. But it's more about the variations from one country to another. And then it's also about what kind of competencies somebody has or credits, if you want. So you could combine all this various types of curricula, and you could come with the same credits to the same end results or the same competence level. I hope I answered the question. I'm not sure.
Definitely. It should be something at the common understanding, like internal medicine, epidemiology, clinical microbiology. These two essentials, three requirements are essential for infectious diseases training, I believe. But I remember we have published a paper more than 10 years ago related to the infectious diseases subspecialty training and its requirements. And the rationale in that paper was that we have analyzed the consultation needs of infectious diseases patients taken into the infectious diseases departments. And when we look at, because the rationale is this, we do need help. What type of need we have in managing our own patients? So we are asking for referral asking for consultation from the other patients. So what type of need we have? Then we'll look at the data in the study. It was a huge nationwide study. As I remember, 38 centers contributed data. I remember that the infectious diseases training does not need the entire internal medicine training. More than this, we need some of the internal medicine subspecialties like cardiology, nephrology, gastroenterology, for example. You know, as I remember, we are in need of approximately 5 internal medicine subspecialties. We don't need much about allergy, etc., etc.
Exactly.
We should, you know, focus on this issue in detail, I believe, or the optimization of our training, because, you know, knowledge is extending too much. We cannot compete with them all. Thank you for everything. Is there any other? There is one more question coming from Dr. Bülent Fetvacı. He asked, where is infection and immunity? How do we position infection and immunity in our specialty training? Or should we?
Well, it's a part. It's a part of non-HIV immunocompromised patients in the curriculum. Here there is some knowledge on immune deficiency in general. That means immunology, kind of clinical immunology, if you look in the details of the program. But of course, it's not the same as immunology per se. It's just what is needed for somebody dealing with the non-HIV transplantation. No, not only transplantations. Now you have all kind of, you know, this target drugs in biologicals that are used in different types of patients, but they could get them immunocompromised.
Yeah,
so
sure.
it's getting really broad.
Yeah, sure.
I can remind to our young fellows who are listening here that it's very good to have a focus area for interest area and to be in the working groups. So within 5 years, you cannot learn everything. In 100 years, medical education's changed 3 times, and there's no perfect way to teach medicine. So we are still searching for the best, but still we're on the way. So for the specialties as well. So you cannot learn everything in 5 years. It's very good to be in the working groups, in ASCMED, in local societies, in EKMUD, etc., and to deep dive in some subjects. And also for immunology, for epidemiology, they have to know that they can continue with Master of Science or PhD degrees after specialties. There are a lot of fellows all around the world, a lot of colleagues all around the world who are making PhD after finishing their specialties, like in pharmaceutical technologies, depending on their interest, immunology or epidemiology or virology, again, to focus on some subjects, some topics. I can refer to those who are thinking to be a researcher or a deep diver in academics, let's say. They can make Master of Science in Immunology, because in immunology, there are a lot of ongoing research nowadays. Like 20 years before, it was not like this, but immunology is a growing area. So in epidemiology, in immunology, in virology, in some laboratory techniques, they can make Masters of Science or PhD degrees to continue and to be an expert on these areas. It's a lifelong learning anymore.
Yeah. It's really, the specialty training is just one phase in the lifelong education of a medical doctor. And especially now when everything is going really broad. But at the same time, of course, during the specialty trainings, an eye physician should reach a level that enables him to answer a phone call, being on call 24/7 in a large hospital, all kind of questions coming, popping up. So there is, it's very difficult to define this level nowadays, because anywhere you could go really broader or deeper if you want. But what is the level that everybody who could be on call should cover.
Yes, you're right. You're right.
Yeah.
So
One more thing, from Roxana, she joined from Constanta. She's a very nice guy. I know her. She asks, I think, to Boyana, saying that the ID specialty is 5, not 4 years.
Yeah, I've seen it. I just sent an SMS to my colleague who collected this data, and we will double check. It's what it came from the Romanian authority, but it might be a mistake. So thank you very much for
Thank
this.
you.
What is very important to make understand for our young fellows is that working with other countries, making collaborations needs common understanding and common knowledge. So it's very good to join this kind of working groups, but also where their education is missing, they can complete themselves as well because there are a lot of sources anymore. The SMIT courses, EKMUD courses, certificate education, etc.
Yes, one more thing. Please let's not forget IDIRI. We have a huge network and we are expecting for young people. Most of the time, we have started the network in Turkey approximately 20 years ago now. Time to time, I feel that we are losing our dominance as the Turkish citizens in the group. So I'm inviting young people to the group so that we can collaborate. And in due course, we are going to focus more on the educational activities altogether. And we will invite such distinguished experts like Professor Boyana and, Professor Zelia as, well-known stars in the world. So we are expecting young people to join us. If they can just send me an email, I will be more than happy to add them to IDEA like Google Group. Also we have social media platforms like WhatsApp groups. That will be great. We can, discuss together the issue in detail.
Okay.
Okay, we have finalized the questions.
Yes.
I think it is time to doing something like tea. Zeliha is, continuously enforcing us here in that context. Thank you very much.
I'm making advertisement for Turkish tea. That's why it's an international webinar. That's why I'm drinking tea now.
So you are still a bureaucrat and diplomat directly focusing on the issue from the other side of the medallion. Thank you very much for joining. Thank you, Professor Boyana. It was a very nice lecture. I'm very happy to listen your presentation. And Professor Zeliha, thank you very much for focusing on the administrative and management perspectives of infectious diseases specialty along with the paper we have published. See you next time, inshallah.
Thank you very much to everybody for listening to us. And thank you to Dr. Selcan for a dedicated work of her.
Also from my side, thank you very much for having me here. Really an interesting discussion.
Very welcome. Thank you and have a nice day.
Thank you to EKMUD making this international webinars happen.
Thank you.
Bye-bye. See you.